Let me get my little stuff squared away and we'll take it from a second. Hello, everybody. Can you see me? Good. All righty. Hey, Candace, there's going to be a Dr. Mahmoud, Arif Mahmoud. If we can unmute him right quick and make sure he's on point with us. Get started.
Hi, good afternoon. Can you hear me?
Mhm.
Yes, hi, Dr. Mahmoud. Yes, we can hear you.
Okay.
Hey.
So let me see. We have hi. So don't ignore my background because my Zoom is used by my son and he just did it. So, let's see. So we have some. So Dr. Edmond, nice to have you with us. Thank you so much for your time. So we have our students from summer course as well as some of our faculty member here. So I want to request to introduce Dr. Bronner is going to join also, but I see that Dr. Hall is with us. So that Dr. Hall, you can introduce a little bit about yourself to Dr. Edmond and the team again.
Okay, got you. So basically, number one, thank you for having me attend. What we did is I worked with my team and we basically reached out to some of the people in our network who we have who've been following along with the story of the quilt makers and kind of watching its impact over the years since we created it. Very quickly, myself, I'm an anesthesiologist and stuff, but I was drawn to this, and I'll tell you in the talk, I was drawn to this because I had a patient who nearly passed away, and one of the major risk factors they had was that they were a brown-skinned woman having a child in America, and that kind of sparked the interest. I'd also done some women's health work on breast cancer, and we were functioning under a grant from the Gilead Foundation. And basically, we were going around Georgia and Louisiana teaching young women about triple negative breast cancer. And so our original story basically dealt that the thing that got me into this was dealing with breast cancer. And then when I had this case occur, I just made it, I got with my sister and tried to figure out if there was a way for us to come up with a story that could change the trajectory on Black maternal health. And that's what I plan on presenting with you today. For those of you who are chiming in, one of the things that when I first started studying the problem, I thought it was something that was going to be one of those chronic diseases, one of those things that can just never be fixed. But then as I started studying the issue more, I came to realize that actually this is a unique problem because it actually can be fixed. And in other parts of the world, it has been fixed. So the reality is in certain parts of Europe, things are already, they've already figured out the solution to this. So when we look at our community, one of the things that I try to get people to do is just look at the examples of communities that have been successful with this issue. But this is a 100% fixable issue, okay? And that's one of the things that excites me the most. The other thing that excites me is that I'm talking to an audience that's based in HBCUs. I fear, Dr. Mahmoud, it's my understanding that, we're reaching down even to Tougaloo, to Morgan State and different other HBCU colleges. And the important thing is with this problem, we have to take this problem. And there's if you remember like doing double Dutch or jumping rope, what I hope to show you over this short, brief discussion is how you can jump in and how you can look at your resources and jump in and affect change on this issue. Let's go ahead and let the other doctors introduce themselves, Dr. Ophir. Hey, Candace, we can let them in.
Yes, everyone's in. They may just have to unmute themselves.
Okay, cool. Who are the other doctors that are part of the program and stuff?
Hi, I'm Dr. Joyce Hall. I'm up here in New York based, and and working with Morgan State with them on the Maternal Health Coordinating Center as one of the principals working out the mentoring component of the research center and coordinating center. So my background is maternal child health, adolescent health. And I did my dissertation on preconception protective factors associated with preterm birth in Black African American women and non-Hispanic white women in New York City. So,
Excellent. It's a pleasure to meet you.
meet you.
We have Dr. Belcher from KKI.
Oh, yes. So I know most of you all know me. I'm a developmental pediatrician by training. So I have worked with women who have alcohol and drug dependent as a preventable cause of developmental disabilities. And I'm a professor of pediatrics at Johns Hopkins. I'm the vice president and chief diversity officer at the Kennedy Krieger Institute, and I'm also jointly appointed in the Department of Mental Health at the Bloomberg School of Public Health. So it's all about you all, the next generation, and understanding the root causes that Dr. Edmond is talking about that is preventable. And so we're about elimination of health disparities. That's what we're about, and working with you all to do that work. So I'm very honored to be here with you.
Excellent, excellent. Okay. Anybody, any other instructors on board? Or physicians?
I think you can get started. Dr. Bronner, the director of the program,
Hey,
is
Candace?
about to join.
All right, Candace,
Uh,
here, so I can just click on my slideshow, Jaja's slideshow. Do I just click
Yep.
share?
Yep, you
Okay,
can share. You can take.
Okay, then, so that's my screen. So what I want to do is, let's see, let me double check. I want to, okay, cool. Let me see what screen I have. Hold on, let me just make sure my. Okay, gotcha. Okay, let me get this rolling and let's get ready to do it. Okay. Number one, thank you very much. The title of this discussion is using art to heal, and addressing the Black maternal health crisis. They've already sent out kind of like my bio, and I'm an author, but basically, I have no conflicts of interest with this work or with this presentation. When I look at myself, number one, I'm a husband, a father, a brother. I'm an anesthesiologist. I'm an author, but most of all, I try to be a child of God. This is my older sister, Sandy, who helped to write the book with me. And basically, she helped to develop the story. So, and she is the person who really taught me how to read. And so when I write, I still write in using her voice a lot. But she's my inspiration, one of the best people I know and stuff. This is the Dream House Make a Difference Foundation team. We have Zaza Lambert and Candace White, who are on with us tonight. They manage us, but they also really are the creative force in terms of figuring out how to better market and position some of our women's health efforts. And they really were like instrumental in terms of getting us the grant from the Gilead Foundation. And one of the goals of this is actually to spread the word so that we can find people who we can partner with. Basically, the book has some teaching points on it. And basically what we're trying to do is address, of course, the high incidence of death for Black women during pregnancy. I hope that I've already mentioned that this is an issue that has already been fixed. But what I want to do, hopefully, in this talk is basically touch on different things that you may look at as something that so that you can understand it's an issue that can be addressed, but more important, just give you some ideas on how you could address it with your organizations. The goal is to advance your understanding and position you for action. If at the end of this you don't feel like doing anything, I haven't done my job. For the young people who are at the HBCUs, the reality is this is going to be your problem to fix. So this needs to be in the hands of people who have public health degrees and a great understanding of how public health in our country and community work. Basically, we've all heard of it. We've seen it in the headlines. The big question is, why are Black mothers in America dying at such a high rate? The reality is the overwhelming concept that we always start off with when we give a talk is the concept of reproductive rights. And reproductive rights simply, it's almost like an extension of civil rights and human rights. But what it says is that a Black woman or brown woman should have the ability to have a safe, respectful, available, accessible, culturally acceptable and sensitive and high quality of care during each phase of having her child. And when we look at the phases of having a child, if you look at the bottom of this slide, you'll see we do the preconception care, the antepartum before you deliver, intrapartum when you're delivering, and then your postpartum care period. At each one of those stages, we almost take for granted that women should have these rights, but unfortunately, our healthcare system is not necessarily designed in order to meet all of those needs. We've seen the headlines. We've heard about the Kansas City cheerleader, Judge Hatchett's daughter-in-law, Terry Bowie, the Olympian. The reality is that it's a shame because this is something that should be a right regardless of race background. Everyone deserves a healthy pregnancy and childbirth. We have to start with that premise, and because that's kind of like the platform from which we'll be working on. In terms of the tools that you have, some of the students and some of the people here, I've sent out a copy of our Black Maternal Health Link survey. I've sent a copy of the audiobook link so you can listen to the audiobook for the next couple of days. They'll post a free link on the chat room and stuff. And then we also have the PDF audiobook companion that I have in there for you, okay? Basically, learning objectives. First, we're going to do Black maternal deaths. I'm just going to give you the bullet number to establish the urgency of the issue. We're going to talk a little bit about the causes. It's not going to be exhaustive, but what it is just going to talk about the broad categories. And then we're going to introduce you to a little bit about this Mother's Health Support Network. These are some of the concepts that I'm sure you guys have been covering in your classes over the course of this summer. But what I want to do is try and put them all together for you and see if we can make them gel a little bit more. At the end of it, what we'll do is we'll take you through the story, what our thinking is, and we'll entertain some questions from the audience. Basically, this is a quilt. We had a quilt made for it, but we're going to talk this sessions by numbers over the next 2 or 3 minutes. The first concept I need you to understand is maternal mortality rate. Your maternity mortality rate is actually the number of deaths that occur per 100,000 births. And then the other concept, that's a mother who passes away. The other concept is the severe maternal morbidity. That's kind of like the number of severe injuries that occur per 100,000 births. So if I was talking about the two patients, if we look at Judge Hatchett's daughter, that's a maternal mortality rate. We talk about her in terms of maternal mortality rate because she passed away. If we talked about Serena Williams, who had a near miss where she had basically a pulmonary embolism after she had her child and nearly died from a pulmonary embolism, basically, she, my fault. Let me move this to the side. Okay. She would be what's considered a severe a severe maternal morbidity and stuff. But I'm in the military, so in the military, for every one man who gets killed on a battlefield, a certain number of men get injured. So you can tell how difficult a situation is, or how much injury and mayhem is going on by the number of people who are actually injured. And some people believe that for every one woman who passes away in America, you actually have about almost 60 to 100 that actually are injured in some form or fashion. But here's the key. I'm only going to give you a couple of numbers, 4 main numbers. The first number is 2. In the top left corner, it's 2 times. The key is you need to understand that in the past 20 years, the death rate for U.S. mothers has doubled. That's regardless of whether what your color is, your background. In America, it is doubled. But while it's doubling in America over the past 20 years, it's actually improving by about 39 to 40% in the rest of the world. So America is actually looked at as an outlier right now. And they're actually looked at as one of the few kind of like industrialized powerhouse countries. There are only about seven or 8 countries that the World Health Organization has actually labeled as going in the wrong direction in terms of maternal health. But that's not just for Black women, that's for all women in America and stuff. But then what you have is we have this situation where, so when you look at, and these are kind of like old stats from 2020, when you look at maternal mortality, the number of deaths, we far outstrip all industrialized nations. If you look at New Zealand, they only have about 1.7 deaths per 100,000, where we're like, our average is 23.8. But remember, Black women are what? And that ties us into the next number, which is Black women are thought to be actually have 3 times the normal death rate. So if we're looking at 100 women that pass away, this is kind of how it's going to lay out, where you have African-American women who pass away at 3 times the normal rate. So if 2 is the first number we want you to remember, 3 is the second number we want you to remember. And then what you have to understand is the next number is 60, because I want people to focus on the fact that 60% of the deaths occur after the child is out. So while we're all really focused on what's happening in during the 9 months where the mother's carrying the child, it's during the delivery and immediately after the delivery for about 6 weeks, where we're in kind of like a red zone or a high risk zone. So one of the things that I'm charging our group to do is to try and raise awareness of the first 6 weeks after the child is born, to see if we can get the support system to have a better understanding and be in a better situation to support that new mother in that 6 weeks danger zone. Now, the danger zone actually extends up to a year. So if a mother passes away within a year of delivering, they will probably be counted as a maternal death. But now we talk about counting, it's really only been the last 5 years that they've been gotten together and started really doing appropriate counting where you had the appropriate data. And that's why you see new research coming out that's really having an impact. The last number is 80. And if US women are dying at twice the normal rate, Black women are dying at 3 times the normal rate, and 60% of the deaths are occurring after that child is out, what you have to understand is, 80% of these deaths and injuries are thought to be avoidable. Every time a woman passes away in about 40 of the states, there's a detailed assessment of what went into the death and the death of that mother and stuff. And now we're getting that data. And so we're really seeing that what we have is a situation where these deaths are preventable. So it'd be different if, we couldn't do anything about it, but, these are preventable deaths. And because of that, so just to recount 2, 3, 60%, and 80%, that really establishes the urgency for me. One of the things that happened to me, I'm an anesthesiologist. I was taking care of this lady. We did a routine C-section, but then she started bleeding a little bit. We went to the recovery room and bounced back from the recovery room. And that's where I kind of like, I ended up having to run a massive transfusion, giving about 15 to 20 units of blood in order to save this woman's life. And we sent her to the ICU, intubated and everything. But when I went and did the quality assurance write-up, I started seeing all this stuff about the risk factors. Come to find out, really one of the #1 risk factors for her almost losing her life while she was delivering was the fact that she had brown skin. It was at that point that I went to one of the seasoned obstetricians at Walter Reed, and I asked her, I said, hey, when you are coaching your daughter about how to protect herself during pregnancy, what do you tell your daughter? Give me 3 things you tell your daughters. And we use these three insights that she gave to actually serve as the basis for the message for our book. She said, the first thing I tell my daughter is that she's pregnant 45 weeks, 39 weeks with child, 6 weeks without child. We don't let our guards down until after the 6 weeks. And now we know it's extended even more. We don't really let our guards down for up to a year. The second thing is you have to speak out or shout out in the hospital. And we have to use, we have to use patient advocacy early. She said, if there are 2 requests and if the couple makes 2 requests and they don't get proper feedback from their care team, get patient advocacy involved early and stuff. It seems, and it's not that the system is evil incarnate, but for some reason the system has a problem hearing women and Black women. And that's one of the things I noticed as an anesthesiologist. I would sit I'd sit in a room sometimes and watch a board certified, qualified cardiothoracic surgeon have to ask for something 3 times, where in other times, some other guys would come in and just ask for it and it'd be there for them. So that showed me that sometimes women are not necessarily heard. The next thing is 8 is excellent. We talk about the prenatal visits, 8 prenatal visits, and at least 4 postnatal visits. And the last thing is something that I kind of added and saw as I was reading and studying this issue, and I incorporated it into the story. And that is that there are long-term effects from sexual assault. And sexual assault has an impact on healthcare. This is the cover for it. It's called The Quilt Makers. It's available on audio. Like I said, we're giving you guys, for the students, if you don't have a copy of it and you're in the Morgan State program, we'll be happy to get some copies to you. For those of you not, you can listen to the audio book, get it on audiobook or Amazon. We give partial proceeds to support Black maternal health. So every, part of every dime that's raised by this, it goes to support Black maternal health, and anything we raise in the month of April goes towards that. So very quickly, while we were working on this, the CDC basically came out with the Hear Her campaign, which is basically designed to show and teach the community about what the maternal warning signs are for a Black mother in distress. They listed about 13 or 14 of them. I'm not, for the sake of time, I won't get into them, but basically to sum them up, they deal with either blood pressure, bleeding, blood clots, or infection, okay? But one of the things that I did when I wrote the book, I was using up-to-date references and resources. So what I do is basically incorporate the lessons from the Hear Her campaign into the story. People tell you to check your blood pressure when you're pregnant, but you really don't have a clear understanding of what the course looks like and how rapidly it can deteriorate if you don't check it. So it's a snippet in the story. What I do is actually outline what happens if your blood pressure gets out of whack. Very quickly, so that establishes my urgency. That's kind of like part 1. This is April Valentine. Excuse me. Her husband is the father of her child is a gentleman named Mike, who is an advocate. She passed away in California a couple of years ago during a routine childbirth. She had a doula. She had everybody linked in to her care, and the midwife and doula and everything. But what happened was on the day of delivery, the midwife wasn't there, and the entire plan fell through. And as a result, she lost her life. This right here is a symbol. It's called it's called kind of like a jagged cross. The reality is it's a symbol from the Underground Railroad. And what it means is that you should proceed with caution and stuff. Wear a disguise and proceed with caution. So one of the things that I do in writing the book is to actually draw from art themes from the Underground Railroad in order to incorporate them into modern day ways of helping people. So that's Black maternal deaths by the numbers. Let's talk about some of the causes right quick. If you look at the causes, and you can separate them into individual causes, relationship causes, or how that individual relates with their support system and their community. And then you got community issues, and then you have societal causes. Basically, the first thing I want to do is kind of lock you into what kills Black women. You know, we know that they pass away, but this graph, I like this graph because it's something that actually shows what's causing the most injury. If you look up here by color, for non-Hispanic Blacks, if you follow my arrow, you can see that preeclampsia and eclampsia, or hypertensive events, are number one. But one of the things that exists for African-American women is the high incidence of postpartum cardiomyopathy. And so in other words, you almost have a heart failure to develop surrounding pregnancy. And the symptoms from that are difficult to assess. You have shortness of breath, extreme swelling of hands and feet. So it may look like a postpartum eclampsia, but the reality it may be postpartum cardiomyopathy. So in that 6-week window, and extending, if you within this, once you get outside about 6 weeks, the incidence of postpartum cardiomyopathy drops off to about 12%. But up until that time, we want to teach our family members, we want to teach the spouses, we want to teach the brothers, we want to teach the mothers, everybody, to recognize some of the symptoms of a woman in distress. Our hypertensive syndromes, we talk about preeclampsia. The reality is the worst case is what's called HELP syndrome, whereas your hypertension gets so out of whack that basically you start getting, your organs start getting affected, and you can start having hemolysis of red blood cells, elevated liver enzymes, low platelets. The reality is if you develop HELP syndrome, 25% of the time the mother dies. So that's why we get on top of hypertension very quickly. That's why once the placenta is at about maybe 33 weeks, once that placenta is big, is mature enough to start secreting hormones that can cause that hypertension, we watch you very closely. So instead of getting what we're trying to promote, and this HELP syndrome, it can develop post-op as well. Okay, so eclampsia and preeclampsia can develop after you deliver the child as well. So what we're trying to do is say, hey, instead of getting them that Cartier bracelet, you know, slip them a automatic blood pressure checker, you know, in that first 9 months, and get that mother used to checking her blood pressure on the regular and recognizing what's normal and what's not normal. Some preeclampsia risk factors. You got high risk factors, which are like type 1 diabetes, kidney disease, and autoimmune disease, sarcoidosis, scleroderma, you know. But then also African Americans are listed as a moderate risk factor. One of the things that we're still talking about, individual things that impact having a child. One of the concepts I want to introduce is weathering. And basically Dr. Arlene Geronimus, basically about like the 1990s, she looked at 300,000 deliveries and basically determined what the best time it was for a Black woman to have a child. Well, lo and behold, she found that the best time for a Black woman to have a child was in her teens. And that was not well received. That wasn't really well received when she mentioned it, but she wasn't actually telling Black women to have their children in their teens. She was just following the data. So as she followed the data over the coming years, what she realized is that she had to ask the question, why is it better for a Black woman to have their child in the teens versus at 23 when other people are in other communities are in their physical peak? Well, bottom line is she came up with this concept called weathering. And by actually being Black in America, or being, not so much being Black, but being on the outskirts of society, what happens is it weathers your body. You age prematurely. So with this concept of weathering, what it happens is when you're 24 or 25, you may labor like you're 32. Well, when you're 35, that means you're going to labor like you're 42. So the reality is that she was able to document that this weathering concept actually has a major impact on outcomes. Okay. And so that weathering concept is one thing that affects the individual, because each individual is going to be subject to different levels of stress in their life. And but the stress and the weathering does change your DNA. And it's been documented. So that's a concept I want to introduce. When we talk about relationships, talk about healthcare systems in terms of sometimes healthcare systems, I mentioned sometimes they are not in tune to mothers. There's an inability to be heard. You may have people who have a healthcare system, but they won't necessarily know how to engage. And then you may have some people who have bad prior experiences with healthcare systems and not necessarily run to healthcare systems. But one of the things that we have to do is, and this is a sad thing that I found out a couple of months ago out of Stanford, they basically did a study and they were looking and rethinking about race in medicine. And basically for years and years, since like literally the 1990s or so, they've been using the standards for anemia or low red blood cell counts in Black women. They basically been using lower standards than they've been using in white women. And the reason they did it was because they just did a survey of what a group of women's red blood cell counts were. And they noticed that Black women had low red blood cell counts. So they just said, well, hey, what we're going to do is we'll use a lower threshold for when to transfuse a Black woman. And people believe that if you correct that alone, and ACOG has thrown out those old recommendations, and they believe that if you correct that alone, you will actually improve the survival for many of the Black mothers. So in short, the actual physicians were delaying transfusions of mothers, and we believe that may have had a negative impact on things. You can find out all about that if you just Google Stanford and Black maternal health and anemia. But so we talked about individual relationships, community issues, but then what it is there's this other component called the social determinants of health. Now, the social determinants of health are things that are non-medical that have a major impact on the healthcare of a community and the healthcare of a person. I like the list and everything, but I'm not going to read out the list for you. I'm going to share with you the quick and dirty way that I have in order to remember this. And the only question I ask myself is, what did Joseph and Mary need for baby Jesus? Okay. We're talking social determinants of health. Well, let's look at it. Did they have stable housing? Absolutely not. He was born in a manger. Did they have the support system with them? Absolutely not. Remember, they had to travel to Bethlehem. Was baby Jesus born in a safe environment? Absolutely not. Remember, Pontius Pilate, he did what? He had, when the three wise men came through, he said, hey, let me know where this baby is so I can go praise him. But in reality, he wanted to kill him. So Jesus was actually born under threat of death, So he was born in the most unstable of conditions, didn't have good food or anything like that. Those are some of the things that are the social determinants of health. So if you want to put your hand around some of those, just ask yourself, what did Joseph and Mary need? If you want to go a little bit deeper on social determinants of health, all you got to do is ask the next question. Hey, what were the gifts of the three wise men? Okay. Well, they gave gold, frankincense, and myrrh. All right, let's start with myrrh. Myrrh is actually a bitter root, but what it is, it's actually one of the most expensive healing agents that's in the Middle East, and that's in that part of the world. So when the wise man gave her myrrh, he was actually giving her an antiseptic, an analgesic. If you remember when Jesus was on the cross, they tried to give him some wine with a bitter with a bitter herb in it. That herb was myrrh, because what it does is it takes away pain. Okay, so when the wise men gave her that, it's almost like giving her the most expensive health care available at the time. Frankincense is an incense. You burn it to get a sense of well-being, but it's also used for medicinal purposes as well. And then if we look at gold, gold was, given because what? Hey, Joseph needed to travel to Egypt. He needed to travel safely. He needed to establish a new home. He needed to establish support for Jesus so he can go get his education in the schools there. So the key is, if you look at just look at what Jesus and Mary needed and what the three wise men gave him. It's a simple way for you to understand the social determinants of health. All right, that's my preaching. But one of the things I have to have you take home, and this is why it's important for the public health brothers and sisters, especially at HBCUs, to get it, is because we talk about some of the physical things and how they die from hypertension, but the reality is you have spiritual killers as well, and that's mental health disease. 80% of women are going to experience mental health mental health or the blues during pregnancy. 20% of them are actually going to need medication. But no matter what I say about preeclampsia, hypertension, bleeding out after you have a C-section, the number one killer of pregnant women in America is violence. And that came out, and when they did and looked at the statistics, violence is the number one killer. So the reality is that having a child in a safe place, being in a safe home is critical for mothers. And with this violence, to take it just one more step, 68% of the times, the violence that's perpetrated against mothers is actually through the use of a gun, a handgun. Okay? So in short, we really kind of have a little gun problem that's playing a role in terms of the survival for the mothers. But you can combine the bleeding, infections, and pulmonary emboli all together, and hypertension all together. It's still not going to be more than kill as many people as violence will for the mothers. It's a public health issue. That's why we're talking to the right audience. Okay, let's keep it moving. These are some of the social determinants of health I talked about a little bit. We talk about safety, housing, access to care. But one of the things that we have to take into consideration is this concept of insurance deserts. It does you no good to be located in a near an institution that can take good care of you as a pregnant woman, but not have access to it. So that's one of the things in America we have to take into consideration as well. Insurance deserts. But guess what? They're maternity care deserts as well. Some places you have to drive, an hour in order to get just good basic maternity care. And also remember, in certain parts of the South that didn't accept the Affordable Care Act, hospitals started closing down like crazy. So you basically had communities that were losing access to basic maternal health care and stuff. So I mentioned those two things because they play a role, but the main thing I want to talk about right quickly is the workforce changes. And we talk about causes of the maternal health crisis in America. One of the causes is the workforce changes that are occurring in America. In America, we have physicians, nurses, midwives, and doulas who participate in the birthing process. The only two that catch babies, that means delivers babies, are the physicians and the midwives, okay? Now, the key is, I got to take you back for 3 minutes to something called the Flexner Report. In about 1910, Carnegie basically hired an academician to go look at every single medical facility in America and determine whether it was up to snuff or not. The reason they did it was because they wanted to determine where they were going to send money and where they were going to invest in the healthcare system. Well, when they did it, 3 things resulted from it. Number one, when they did the review, they used Johns Hopkins, and I'm at Johns Hopkins right now. They used Johns Hopkins Hospital or a European German model as the standard bearer. So you need to have good research facilities. You need to have good clinics. You need to have top-notch clinicians and didactics going on. But what you have to understand is, you know, when they did that, if you look at the middle of the slides, man, after they did it, actually, they ended up closing down of the 155 training sites. They ended up dropping down to 85. Okay. And the other thing that doing it did was basically it almost established the gatekeeper for women's care and for all healthcare was a college educated white male who had resources. Because even back in 1910, if you to get 2 years of college, you had to kind of like be rich. So a guy who's kind of working himself up from the bottom, from the farm and stuff like that, you know, it's tougher for them to get to it. So the bottom line is the net impact of the Flexner report was a decrease in women in medicine, a decrease in minorities in medicine, and a decrease in people coming from a lower socioeconomic class. When Flexner report started, there were about like six or seven, I think, maybe even 8 Black medical schools in America. After Flexner report, there were only 2, Howard and Meharry. But you want to hear something worse? Before the Flexner report, there were 7 or 8 schools that were actively training women. And you actually had the Pennsylvania School of Women, which was one of the top medical schools in America. After Flexner report, they closed that down. And they closed down all of the women's medical schools. So basically, and then for the lower socioeconomic, University of North Carolina was on the list to be closed until they made changes. So the key is they really, and at this time, what that did was by making that the white male, wealthy male, the gatekeeper for healthcare, they also were able to move midwives out of that position as well. And in short, what they did was set about saying that women need to have their child in a hospital, if possible, because it's more clean and safer. But they were saying that without really having all the data. And what you have to understand is up until about 1940, 75% of any American who was born in the country was born with a midwife. And you also have to understand there was a time when basically there was a value placed on the Black child, and that was during slavery, because every child that made it through successfully added to the wealth of the master. So so the master made sure that the technology, the information, the training of those midwives, he didn't make sure they were there. The midwives were superior, and the midwives in the South took care, and all of America took care of Black and white together. So this is these are some of the classes of the midwives that we have, okay? But the key is, for the young people, I need you to understand what 100 years effect is. If I tell you for 100 years you were missing 200 women physicians, that's a lot of women who didn't get out there and affect the community. If I tell you you're missing 6 medical school classes worth of Black doctors, then that has that's a negative impact. So the reason we are where we are has to do with the workforce changes that were made back then. In essence, with midwives, what they did was really nice. They said, hey, you know, we want all the children to be born in a hospital. But what they didn't tell people was that they were not going to allow women to be credentialed, and they were not going to allow Black women to be credentialed at all. So in essence, in putting the birthing and taking it out of women's hands and putting the birthing process in the hand of these men who were kind of like, you know, erudite, intelligent, you know, academician guys, it took it away from women. And that's different from other places, because if you look at the outcomes for in terms of the maternal mortality rates across the world, the ones that have the societies that have a high impact from midwives actually do the best. They do the best. So in Europe and all of those other places, if you look at the top in Australia, a large percentages of the births occur from midwives. UK, the same thing. If you look at the US, there's a flipping of the number of births. The doctors deliver more births than the midwives in the US and in Canada. But we're 2 of the countries that are struggling And the reason, so one of the real things that when we talk about cause from a public health standpoint, you got to understand the impact of the workforce. Again, I mentioned as a result, you have these maternity care deserts. If you look down in the South, you're not going to see a lot in the South, which is a high risk area for delivering children and stuff. If you look at the maternal rates down there, they're always a little bit higher. You're going to see there's not good penetrance of midwives. Maternity care deserts, absolutely. Okay, very quickly. So we talked about poor access to care. Let me get this thing moving and stuff. I'm trying to, we got going. Okay, here you go. I do need to mention another caregiver, which is a doula. In Europe, doulas play a major role. In Finland, which is okay, I'm gonna wrap up in a little bit. In Finland, which is the country that I kind of like studied and drew a lot of information from, doulas play an integral role and do the lion's share of training of the mothers during the birthing process. Well, what a doula is basically an advocate, someone who can recognize a mother in trouble, and someone who can basically deal from a spiritual, physical standpoint to make sure that mother has a good result. She is a trained professional. She gets paid by Medicaid. They are an advocate for the mother, and the studies are coming out left and right, basically showing that if you have a doula, you have better outcomes. Okay, so I just want to introduce that to you. Other than doulas, I do want to introduce you to the concept. There was a time, and if you go over to Ghana and have a child, your cousin's going to move in for 6 to 8 weeks, and she will be the advocate for the mother. The reality is within our families at times we have people like Big Mama who just had helped deliver a lot of children who would come in and help the cause. Nurses will move. Okay, so those are kind of like accomplishes our learning objectives. This right here is just a quick picture. You can go back and find it out more about it on your own. It's a New England Medical Journal article that just shows all the pieces and what would be present in an ideal situation. But we can go to an ideal situation if we look at that Finnish maternal health care system. And the thing I want to take home about Finland, and it's just this one slide, is you do a comparison contrast between Finland and the US. In the US, we're 23 plus deaths per 100,000, 60 plus deaths for Black women. You're 3 deaths per 100,000, 2.7 or less in Finland and stuff. The US has medical center-based care. So if you notice, everybody thinks they need to be delivered at Northside. Finland, they basically have a community-based, where they have community, easy access, community facilities, where you have qualified nurses, midwives, and doulas who help you with your care. So the same team that takes care of your first child is probably going to take care of you and your third child. The beautiful part about it is they do have doctors, and they have the doctors involved for the high risk, but the average delivery over in Finland is taken care of by 2 midwives, and they have an OBGYN doc that they can contact if they have any problems and stuff. Doulas do, like I said, do the lion's share of training during the prenatal period and stuff. Other than that, one of the other things we have to take into consideration, universal insurance is in Finland. In America, it's going to cost you $12,000 or $13,000 to have a child. Okay, maternal and paternal time off. That's happening over there and not here. So what I'll do very quickly is at the end of this study, it says something interesting. It says the data suggests that it is the structural difference between the two healthcare systems that explains the discrepancies between maternal outcomes between Finland and the United States, rather than solely the difference in actual individual maternal risk. It's the systems. Our people made a conscious decision to go into a system that basically doesn't invest in maternal health care. To close out the next 10 minutes, I'll just talk about how what the Edmond project and kind of what we got into. Basically, I told you I got involved initially doing breast care work, and we were able to use art in order to come up with a new way to do breast examples. I told you about the case I was in and how I made a commitment to work with my sister to try and write a book. And that's exactly what we did. And we use this concept called using art to heal. And what we do is we include up-to-date data and medical information in our storylines. We tell a story that's deep with cultural roots, Southern traditions and roots. And we use arts as a theme throughout and stuff. And we actually introduce people to the Underground Rail system and things of that nature. The cover is a work of art. If you look at it, we basically had a real solid graphics artist put it on there. And when and the book has inspired art. This is a quilt that was made to go along with the book itself. It has the different motifs and patterns. The only pattern I want to let you guys know about right now is the log cabin. The log cabin pattern means that you're home free. Okay. And what we do is also use a true graphics artist, which is Ruud Van Empel. He's in Amsterdam. And he basically loaned us one of his images to use as a focal point for discussions in for art in the piece. And we really go heavy duty in the traditions. We talk about things like haints. We talk about things, we talk about the book has a real strong theme with Zora Neale Hurston. And the beautiful part about studying and writing something, you know, we thought we were just going to write this book about giving birth in a safe way. We come to find out that our auntie, Aunt Stella, was a midwife in Lawrence County where we were from. And basically, this is the true Aunt Stella. And she was a midwife, one of 2 midwives in Lawrence County, Georgia. She delivered Blacks and whites. Renaissance woman, kind of interesting life as we get closer to it. Come to find out, she actually married a white man. You know, it's an interesting, just an interesting sister indeed. But the bottom line is we took that medical message that the OBGYN doctor gave us and we incorporated it into a nice storyline. But what we did was, instead of having all negative storylines, what we did was we created a utopian environment where we said, okay, what would it be like if we came up on a county where, say, every place in Georgia was having problems with a mother's dying, but suppose we created a county where no mothers were dying, where you actually had solved the problem. So we take a look at the problem from that angle. And we have Alpha, who's the anesthesiologist, goes back and basically investigates, you know, why the death rate in our home county is so low. There are themes of sisterhood in there, how to work with what you got, you know, the whole math concept, what's you given, you know, how to be a good listener. We really have focus on listening and describe people who are good listeners versus people who are not good listeners. Because remember, being heard is one of the major things, limitations that's happening. And one of the things that we think has been affecting negatively the mothers. Other than that, we also talk about God's power to heal people. And we also talk about the strength of community. But in the end, we really focus on the Hero campaign and really try and push that as well stuff. So one of the things we do is there's a survey link that we gave you guys for the students, and you guys can get it if you want it online. But what we do is we basically go through and ask a couple of simple questions. We ask, hey, do you know someone who had a major event during childbirth? Did you know 60% of issues happen after the delivery? How familiar are you with preeclampsia? Do you know maternal signs of distress? How comfortable are you communicating to your healthcare providers? And have you ever used a patient advocate? And do you know what one is? And this is just meant to break the ice to get people where they want to. We capture it and we use the results primarily to push forward discussions. One of the things that that I'm focused on is basically trying to start an organization called Brothers for Black Mothers, and our focus is going to be on basically getting the support teams ready to support Black women during that first that 6 weeks of that first 6 weeks after the child is born and stuff. Now we're going to support all the way through, but definitely after that, guys. What it is I think we accomplished our learning objectives. I do hope this gives you an idea of some of the things you can do when you go back to the HBCUs. April is Black Maternal Health Week, okay? And by being in this program, if you don't do anything during Black Maternal Health Week next year, you ought to set some type of project off so that you can educate people in your communities, in the HBCU communities about this issue, once again, which has already been fixed. Hey, I'm gonna stop right there and take some questions and stuff. I appreciate you guys hanging with me, and I hope I came through okay. But let's go ahead and open up the lines right there if we can, Candace. Oh, my fault. Candace, I need to show one thing right quick. Can we just show that, close out by showing the video? Let me see.
Give me 1 second, let me cue it up.
Okay. Okay. And I still got the screen?
Yep, you still got it, Doc.
I still got the screen?
Yep.
I do?
Yes, yep, it's still yours.
I'm
It's
gonna
it's
turn,
still showing your screen, so if you hit play,
all right, I need to turn my volume down. Sometimes it echoes a little bit, okay?
okay.
Well, this is kind of like sums up kind of where we're going with this. I hope you guys enjoy the audiobook, but this is kind of
Hey, Dr. E, this is Nadrick. How you doing?
I'm good. Can you hear?
Yeah, I
We
can hear
can't,
you. Can you hear
we
me?
can't hear
Can you hear the
we
video?
can't hear the video, Doc. You want me to play the
Okay,
3-minute one?
Yeah. Can you let's see if we can, how can we get this video up?
Okay.
I
The
think you need to
3
share your sound.
Share my sound?
Uh,
I bet you're absolutely right. You are screen sharing. Let's see.
Let me see, Doc. I might take it from you. Hold on.
All right, that sounds good. I want to share my sound too. Share sound. Oh my goodness. You got me. Okay. All right. I'm sharing the sound. Okay. Candace, let's give it
Okay.
a shot. All right, guys. Okay. Let's give it a shot. Right now.
Doc, I can't hear anything. You want me to try it? I have the video queued up.
Yeah, you can.
Okay, so just stop share if you don't mind.
Let's stop share.
Yeah.
All right. Let me see. Back to the top. So you just stop share.
Yes. You see that option. It should say stop share.
Share layouts. Share.
Let me
Screen.
see.
You got it?
All right, I'm gonna take it over now.
Okay, got
My sound is shared.
you. Oh, got you. Ooh, great questions. Got you. Get that.
Today, a woman, an African-American woman, nearly died following the birth of her child.
God, that's horrible. That can't be normal.
Unfortunately, it is. African-American women are 3 times more likely to die surrounding childbirth than their white sisters in motherhood.
Really? Why is that?
No one knows. Except for one place. My hometown. I'm going there to find out why.
Right now. And go.